Stroke. Let's learn some basic concept about the stroke. First of all, we talk what's the definition of stroke. Well, the definition goes, it's an abrupt onset of a non-convulsive focal neurological deficit, and that deficit lasts for more than 24 hours. Now we'll do the analysis of each and every word. The first thing is it's abrupt onset. Now you got to remember, in case of neurology, if something happens suddenly, three things should come to your mind. First, either it is traumatic. If trauma is there, history will be always there. That should not make any difficulty in diagnosis. Or second is convulsions. They occur suddenly. Again, there's a classical history. Of course, at the relevant, I'll talk about motor seizure, so-called convulsion. History will be there. Okay, in this we can know by history. But if there's no trauma or there's no convulsion, then anything in neurology of sudden onset is always vascular in origin, unless proved otherwise. So I hope you understand the meaning of sudden onset. So whenever you'll be getting a question, sudden onset is, you should point toward the vascular phenomena. So we are clear about this thing. Non-convulsive, I told you that convulsion can come as a acute manifestation, but history will be there to confirm it. Or otherwise, if any doubt, EEG is the one which is going to help you. Now, what is the outcome of stroke? Any focal neurological deficit. That means patient will have some hemiplegia, paraplegia, whatever it may there. So patient will have some feature. But what is that? The deficit remain for more than 24 hours. This is again a very important point. Why? Because soon I'll be talking to you regarding TIA. TIA is almost same. The only difference is again the problem that the deficit resolves within 24 hours is TIA. TIA is transient ischemic attack. So I hope you are clear about the definition of stroke. So I was talking to you regarding TIA, that focal deficit lasts for less than 24 hours. That means patient has some problem, but within 24 hours patient become perfectly all right. But patient of TIA come to us. He has some hemiplegia which lasts for maybe 10 hours. Now he's all right. So is he all right? Should we say nothing, worry about it? No. We have a ABCD2 score about which I'll talk soon, and that indicates that patient is more likely to go into more deficit, or he's more likely to go into stroke if ABCD score is high. The patient of TIA should be warned very clearly. It's a warning sign that he's likely to get more problem later on. About this I'll talk soon. And one more thing, TIA is always ischemic. It is never hemorrhagic. This point we should be very, very clear to you. Now, what are the causes of stroke? Especially at the moment I'm talking to you regarding ischemic stroke. Cardiac origin, the site of the origin of the clot may be from cardiac, and these are usually embolic. Okay. So what are the source of embolus? Come from the heart, and one of the important thing is atrial fibrillation. And why? How can atrial fibrillation lead to this problem? So let's learn the basic concept about AF. Well, this is the heart, and they are the atria. Now these atria are fibrillating. So and one more thing, I hope in the cardiac cycle, in the late diastole, atria contract and 30% of the blood is pushed from atria into ventricle by the atrial contraction, and this is known as atrial kick. This occurs in late diastole. In early diastole, when this ventricle dilate, this valve open and 70% of the blood come from atria to ventricle, and this is known as rapid filling phase of myocardium. And during this time, third sound is produced. If it has to be there, it comes in the early third stage, early phase. That's why third sound is known as filling sound. And the atria contract that produces S4, and S4 is known as atrial sound. But what I want to convey the message is atrial contraction can push 30% of the blood, and if atria are fibrillating, this 30% of the blood will not go into ventricles, and there will be stasis of the blood into the in the atria, and then stasis, anything in the blood stasis, I hope you know that it predisposes to clot formation. So clot may form in LA as well as RA. It's very essential to know that clot form in RA. Why I'm emphasizing on this word? Because this clot will come to ventricle, left ventricle, go to aorta, and will lead to systemic embolism, which can lead to stroke, about which I'm talking to you. But don't forget, clot may form in the right atria also, come to the right ventricle and can go into the lungs, and that's the reason why pulmonary embolism can occur. So I hope you are clear about the atrial fibrillation as a source of embolic phenomena. So now other things that is endocarditis. Infective endocarditis especially is very important because it's a source of septic embolism usually, and this is especially common in IV drug abusers. But one thing is there, IV drug abuser usually involve the right side of the heart. So tricuspid valve is involved, and that can lead to pulmonary embolism. But in a case of endocarditis, otherwise native valve endocarditis is more common in the mitral valve, and that can lead to so-called stroke. Myocardial infarction is again clot formation can occur. This can have a embolic phenomena. Myxoma, especially it arises in the left atrium with the most common side of, and it can detach and it can have a embolic phenomena. Dilated cardiomyopathy, again because of impaired contraction of the heart, that can lead to embolic phenomena. And now come a question for you. You can stop the video and write down the answer. Now we have a term called paradoxical embolism. Tell me, in which condition you see this type of embolism? Write down the answer in your copy. So I hope you have written the answer. The answer of that paradoxical embolism occurs in tetralogy of Fallot. What is the meaning of paradoxical embolism? We know very well that a venous clot in top can enter the aorta and it can lead to stroke. So this phenomena of venous clot entering into arterial circulation is called paradoxical embolism, and I'm sure you must have written the answer correctly. So now we talk about connective tissue diseases. Now second part which can lead to some ischemia is connective tissue disorders, and the usual reason why they can is vasculitis. Because vasculitis is very common in connective tissue disorder. Various disorders like SLE, rheumatoid arthritis, scleroderma, Takayasu, they all lead to vasculitis. Okay, and Especially there, they may involve the small blood vessel or medium blood vessel, and that can lead to ischemia. And one of the classical findings, what we gain again in this type of problem is in giant cell arteritis, which can lead to involve the retinal artery and which can lead to blindness. Now I'll talk this syphilis. I like to mention especially about this, especially neurosyphilis, which is a type of tertiary syphilis. And regarding tertiary syphilis, it is well known it can resemble any neurological deficit. Any neurological disease can be mimicked by neurosyphilis. So of course, it can also mimic like stroke also. Now regarding hematological condition, there are so many conditions, and the main pathology is hypercoagulable. So they lead to increased clot formation, and some conditions which are known for this is polycythemia vera and essential thrombocytosis, multiple myeloma, protein C and protein S deficiency, PNH, that is paroxysmal nocturnal hemoglobinuria, EPLA, that is anti-phospholipid antibody syndrome, which is typically seen in SLE, and that can lead to formation of clot in both artery and vein, and sickle cell anemia. Something very interesting. Sickle cell anemia can lead to stroke. In fact, it can lead to ischemia of any organ of the body. But this is not due to hypercoagulable state. But why this happens? Because let's say this is a blood vessel and they are the sickle cells. These sickle cells, they tend to adhere to each other, and that's why they can block the microcirculation by clogging to each other, but not due to proper clot formation that we talk about. So sickle cell anemia can also manifest like stroke. So I hope you are clear about the three main reasons of what we can have this can lead to more of a clot or embolic phenomena. Now miscellaneous conditions which predispose to stroke are pregnancy. In pregnancy, and of course we also talk about oral contraceptive pills. Now again a question for you. In oral contraceptive pill lead to cortical vein thrombosis. Now the question is, you can stop the video after listening to the question. Tell me any blood condition, any hematological condition where cortical vein thrombosis is very common, which is rather a known complication, and that is the leading cause of death in this patient. Okay, I hope you have written the answer by now. The answer is PNH, paroxysmal nocturnal hemoglobinuria. Again, cortical vein thrombosis is very common and is a leading cause of death in PNH. So we come back to our main point discussion. We got many extra information for you. There are certain drugs which can lead to stroke, and out of these, most notorious is cocaine. Is a drug abuse, and why it lead to intense vasospasm. So not only it lead to CVA, it can also lead to coronary artery, you can see it can lead to myocardial ischemia also, it can lead to MI also because of vasospasm. Amphetamine is other drug which can lead to this problem. An infection like tuberculosis, which lead to vasculitis and which can lead to stroke. Now, very important point, most common cause of stroke in young women using oral contraceptive pills is, as I told you, cortical vein thrombosis. Okay. Now, risks of stroke following TIA. The very beginning I told you, a patient come, he has maybe hemiplegia, and that hemiplegia lasts for 10 hours, recover fully, so what we call as transient ischemic attack. Then we counsel the patient that he should take proper treatment, otherwise he is more likely to get stroke in future. For that we use ABCD2 score. So let me tell you what is this ABCD2 score stand for and what is the importance of this thing. A for age. If the age is above 60 years, we give 1 mark. B for blood pressure. If systolic BP is more than 140 or diastolic BP is more than 90, we give 1 mark. Here point to be noted is and oblique or, either of them. Patient may have BP of 120 by 100, so that will be taken as 1 score. Or patient may have BP of 170 by 80, that again we get 1. But if patient has BP of 180 by 100, then also he will get 1 mark. It's not that 1 for no. Point to be noted, any abnormality and or patient will get 1 mark. This point should be very, very clear to you. After that, we talk about the clinical features. If the patient come with unilateral weakness, what I can say, patient come with hemiplegia, you give 2 marks. But if patient come with a only speech disturbance without any hemiplegia or without any motor weakness, that patient will get 1 mark. But if patient has motor weakness plus speech disturbance, then again he will get only 2 marks. This point should be very, very clear to you. Let me tell you what's the importance. When we talk about unilateral hemiplegia, most likely problem is in the internal capsule area. It can be both right or left. Patient get 2 marks. But if some motor speech disturbance is occurring, that is understood the lesion is in the dominant hemisphere. And that again indicate middle cerebral artery because some problem is there, but without any motor weakness, patient get 1 mark. The point should be clear to you. Then we talk about what the duration of TIA. If the duration of TIA is between 10 to 59 minutes, you give 1 mark. But if the duration is more than 60 minutes, then you get 2 marks. Like I give you example, patient come hemiplegia for 10 hours, recovers. Within 24-hour recovery is TIA, but lasts for 10 hours, then he will get 2 marks. And last but not least, D for diabetes. If diabetes is there or even sugar control on medication, he get 1 mark. So A for age, B for BP, C for clinical symptom, D for duration, and D for diabetes. The amount of score given is 1, 1, 2. If 2 or 1, either of these will be there. Duration again 2, 1 and 1. So maximum score will be how much? 1, 2, 4, 6 and 7. Total maximum score is 7. More the score, more is likely to have stroke in the next 3 months. So you have to evaluate every patient based on ABCD2 score. Now, pathophysiology of stroke. As far as infarction is concerned, it is there in around 85% cases. That means majority of time it is the ischemic problem and bleeding is there in around 15% cases. And here also we got thrombosis. Thrombotic scores are around 25%. Okay, and what the reason of thrombosis? One is lacunar. Lacunar is lipohyalinosis, or it could be microthrombi, formation in the small vessel. And I have recorded a special lecture for lacunar infarction. You can see more detail about lacunar infarct. Second problem is large vessel, which can lead to, and this is usually patients due to atherosclerosis. Risk factor are there. Then in embolic phenomena occurs in around 75% cases of all ischemic stroke. 25% are thrombotic stroke. Now it could be cardioembolic. That means the embolus has risen from the cardiac source, about which I gave in detail, including atrial fibrillation, or from artery to artery. It is usually due to atherosclerosis. Then we talk about hemorrhagic stroke. I told you they are around 15% cases only. And the site of hemorrhagic stroke, it could be intraparenchymal. Out of these 15%, 10% are intraparenchymal, and these are the one which lead to focal deficit. And the reason is hypertension or some AV malformation. Okay, subdural, of course, trauma is always a feature. These two usually occur due to trauma. And subarachnoid hemorrhage, again, remember the commonest cause is trauma. Point to be noted, the commonest cause of bleed is always trauma, undoubtedly. Okay, and of course subarachnoid hemorrhage can rupture due to rupture of Berry aneurysm. It's a very commonly asked question. Remember, in the option, if Berry aneurysm is there, trauma is there, the best answer is trauma. Okay, so these are the so-called hemorrhagic. This is out of this 15% total. This is 1%. This is about 1%. This is about 1 to 3% or 2 to 3%, whatever you can say. That means the most common cause of bleed is intraparenchymal. Well, when we talk about intracerebral hemorrhage, which we discussed just now, history of uncontrolled hypertension is usually there, most commonly. In some cases, there may be coagulopathy or some bleeding disorders can be there. Symptoms, they progress. This is very, very important. Here I like to inform you. Let me show you what happened in the three. We got thrombosis, we got thrombotic embolism and bleed. In thrombosis, usually it is like stuttering. Okay, in embolism, deficit, once it happens, is fixed, but in bleed, the deficit progresses. So when you are taking a history of onset of stroke, be very careful in knowing how the stroke has happened. Stuttering means patient problem, little bit improve, problem, this is stuttering. Embolic is fixed, when it is there, no more progression and bleeding. Okay. And one more thing you should know, that focal deficit appear early and followed by feature of raised intracranial pressure. This is happening mainly in bleeding. What are the signs of raised ICP? Patient may have altered sensorium, headache, severe headache may occur, altered sensorium, bradycardia, and hypertension, increased BP or bradycardia. And they are, this is what is together is known as Cushing reflex. Okay, but one thing more, this raised ICP feature can occur in massive embolism, in massive ischemic stroke, but it never happen immediately. It usually happen after 2 to 3 days, not immediately. Again, stop the video, answer the question, why it occurs, why it doesn't occur immediately, and why it occurs late, and when and why this raised ICP feature occurs. I hope you have written the answer. Answer is it usually occurs after 2 to 3 days. Because in massive ischemic stroke, cerebral edema can develop. And it is this cerebral edema which can lead to feature of raised ICP. So what I want to convey the message to you is feature of raised ICP can occur in ischemic but not immediately. In hemorrhage it occurs immediately. And remember, maximum and the earliest raised ICP occurred in cerebellar bleed, which occurs in the posterior fossa, and because that may hamper the CSF flow because of pressure on the ventricles, and that can cause even there can be even herniation of cerebral tonsil in the canal, in the spinal in the vertebral canal, and that can lead to cardiac arrest immediately. Now remember, the most common site of bleed is intraparenchymal, and of course hypertension is the most important cause of intracerebral hemorrhage next to trauma beyond doubt. Now we are talking about ischemic stroke. Remember, whenever we have ischemic stroke, we always have a atherosclerotic risk factor: hypertension, diabetes, smoking, and increased lipid. But as far as CVA is concerned, hypertension is the most important parameter which can induce both atherosclerosis as well as hemorrhagic bleed. And of course, local in situ obstruction of an artery is the usual cause of thrombosis. And as I'm talking to you, symptoms fluctuate, so-called stuttering type of deficit. Now, embolic histiocardic lesion I discussed, onset of symptom is sudden and they persist. And one more thing, in embolic, to be more precise, can be different vascular territories may be involved, and usually it is not seen in thrombotic. So a quick recap of last minute revision point, what we learned in this lecture. Stroke symptom lasts for more than 24 hours. TIA symptom resolve within 24 hours. And in stroke, 85% is ischemic, 15% is hemorrhagic, and in the ischemic, cardiac, which is embolism, corrective tissue due to vasculitis, hematological hypercoagulable state, and risk of stroke following TIA, we use ABCD to score. Thank you very much for watching this video.